we'll get started. I want to thank everyone for coming. Today, this is the AO Trauma North America Journal Club series. And today we're going to be reviewing some ABOS WLA articles. I am very excited that we've got a fantastic group of moderators today. So I hope that we can have a great discussion about the articles that we're going to be presenting. I'll introduce the moderators really quickly, and then they'll introduce themselves as well as the guest authors that we have with us today. So we have Lucas Marchand. He'll be giving us a presentation today as well from the University of Utah. We have John Morlato. He's from University of Mississippi Medical Center. And then Kyle Schweizer, who's from University of Missouri. We'll be reviewing 4 articles today. We're going to have a small break after the first one just to ask some questions of our guest lecturer, so she can get off to another meeting that she has to run to. So please be prepared for that. And then our other 3 authors will run thereafter. I'll have them introduced by their moderator for each of their sessions. Here's our disclosure slides. And then please make sure that you use the Q&A box for any questions you have. We'll try and get to those for each of the through each of the moderated sessions. And otherwise, we'll try and get your questions as quickly as we can, but we're going to try and bunch all of the other questions for the other 3 articles until the end. And let's get started with no further ado.
It's John Morlato. I'm from the University of Mississippi Medical Center, and we're going to be talking about the study from published in 2019 called a randomized controlled trial comparing the recombinant BMP2 absorbable collagen sponge versus autograft for the treatment of tibial fractures with critical size defects. Thank you for joining us, Dr. Canada.
Thank you. It's an honor and pleasure to be here.
Right on. And I guess we'll just jump right into it. Can you briefly summarize this trial design and briefly describe the results for us?
Well, this study took place between 2011 and 2017. However, the work for this study started several years in advance of that. For a long time, open tibia fractures are a complex problem. And many times there's bone loss, soft tissue issues, and just a hard problem for orthopedic trauma surgeons. And then we know in the late 2000s, rhBMP2 was approved for use in spine surgery. However, for many people, because of the osteoinductive nature of rhBMP2, it was thought to be the best thing since sliced bread, and it was used off-label throughout the late 2009s and 2009 to 2015, used off-label in many trauma situations. And what we wanted to know, is it equal or better than our gold standard of iliac crest bone graft in the treatment of open tibia fractures with bone loss?
That's great. And what, if you could just summarize the finding for this study?
Well, first of all, our hypothesis was it equivalent with radiographic union within 52 weeks without the need for additional or more surgery to iliac crest bone graft, which was thought to be the gold standard. The metric consortium represents a tremendous advance in orthopedic trauma. More than 50 trauma centers across the United States are involved, and there's been multiple articles published. This article represents the first clinical trial results published from the metric consortium. Very proud of the efforts of all the contributors and thankful for metric's involvement. However, it was a lesson in research for all involved. We screened 1,123 patients. In the end, only 55 were eligible. And during this time, there was bad or negative press regarding RHBMP2, resulting in difficulty in patients consenting for randomization, and also clinicians feeling comfortable with some of the negative press which had come out regarding BMP2. In the end, we had 16 patients who received RHBMP2 on the absorbable collagen sponge with allograft, and 14 patients who had iliac crest bone graft. And what we looked at was the time to healing and also complication rates. So we wanted to look at our non-union rate and infection rate. And interestingly, there were 3 infections in the RHBMP2 group and none in the iliac crest bone graft. And we wanted to look at secondary healing, functional outcomes with the SMFA, and also the overall costs, comparing the Medicare cost to charge ratios. So in the end, we had 23 of those patients out of the 34 who had union data. 7 of the 12, or 58% of the BMP group, were healed using the RUST criteria, compared with 81% of the iliac crest bone graft, resulting in a difference in treatment between the 2 groups. And there was lower rates of clinical healing. What did we define clinical healing as? That was full weight bearing with a VAS score of 4 or lower at the fracture site. And they had lower rates of clinical healing, which the rates were just pretty poor overall, 27% with BMP2 and 54% with iliac crest bone grafting. And then when we looked at our functional outcomes, the bother and dysfunction index of the SMFA, there were higher scores in the BMP group, and again, the complication rate. The overall cost was also higher for the BMP2 group at $14,155 versus $9,086 for iliac crest bone graft.
Ultimately, with this study, the iliac crest bone graft kind of came out on top. How did this, or did this at all change your practice?
You know, what you have to think about is the number of years, I've been in practice over 20 years and things have changed. As you know, even since you've been in practice, things have changed. I came out at a time when iliac, in the early 2000s is when I started practice, and iliac crest bone graft was used routinely. But then, what are the negatives? How long does it take to harvest? It's limited volume, and also dependent upon the age of the patient, and, the risk of fractures, and
Pain.
all of that. Pain, fracture risk. And I will say I also did spine surgery for the first 10 years in practice. And I remember I did an ACDF on a college basketball player, and he didn't complain about his neck. He only complained about his iliac crest harvest site.
Sure.
Other things have come out, and allograft products, other products have come out. I do believe, the value of iliac crest bone graft, or really, let's talk about autograft, the value of autograft, because there's other sites. Gertie's tubercle represents a great site for harvesting, and I do that. Right? I mean, it's great. You can get a large volume, I believe bigger than iliac crest. And there are studies that support, a comparable or more volume. Distal femurs or other sites, or upper extremity surgeons can also use, the upper extremity sites, including the distal radius, for sites, or olecranon fossa. There's a lot of different sites. The biggest thing is when you need autograft, or when you believe that's the best thing, I still use autograft.
And so in a hypothetical situation in 2022 with a 3 centimeter bone defect in the tibia, what's your go-to then for a graft?
It's going to be using the Mascalais technique, for 3 centimeters or greater. If it's under 3, it's really, it's great. We all know about the benefits of the Mascalais technique and the harvesting of whether you use autograft or whether you use allograft. For me, it's going to depend on the patient, the defect. There are other injuries, but I will use the Mascalais technique with autograft augmented if I need more than I can harvest. So that's what I do. It depends, because if you have a 5 centimeter defect, you might not get enough to fill with autograft alone. What about you? Tell me what you use.
I'm sort of the same. I like autograft and I'll bulk it with allograft if I need to. I do dabble in some of the proprietary sort of bone graft substitutes, but largely I like the iliac crest. So.
I like it. It depends. You can be very aggressive with the iliac crest. It depends. The younger the patient, the more, it actually is much more attractive. Older patients, postmenopausal women that need bone grafting, it's, that iliac crest, again, it's the patient, the defect, the size, and their other injuries. But definitely allograft mixed with autograft mixed with allograft, and as you mentioned, some of the proprietary products available with Mascalais, I think is the way to go.
And my last question, is there an indication for you for BMP2 at this stage for non-union work or fractured or bony defect?
For a bone defect, I haven't, I believe if something has failed, if the tried and true, if the Mascalais technique has failed, I will go to BMP2 in difficult situations where, but it's more a salvage versus choosing it as a first line.
Yeah, I think I agree with that. And I think a lot of surgeons do. It's kind of the kitchen sink. Once you've sort of run out of options, then you sort of looking for any help you can get.
I agree, and it's desperation, but it does have osteoinductive properties. That part can't be disputed, so we do have to acknowledge that. And when we're trying to take care of patients in those desperate situations, it is useful.
Yeah. Well, we're coming to the end here. We'll wrap it up, but thank you very much for your time. We really appreciate it. This is a great study. It's very interesting, and I think it does guide what we do in 2022. So thank you very much.
And thank you for inviting me to discuss it. And thank you to Metric and all the researchers who committed their blood, sweat, and tears to completion of this study.
Great, thank you. So I guess, Jason, since we did the interview, I'll just maybe ask a few questions. And to all the participants, if you guys have any questions, just click the Q&A button and we can answer them as we go or save them from appropriate time. So, Dr. Canada, this was an interesting study, and it sounds like there was some issues with this, like trying to get the right sample size, dealing with the FDA, and that sort of thing, and sort of plagued the Jones paper as well with small numbers as well, having to get the investigational device exemption and all those sorts of things for the BMP. I'm just wondering, you combine the two studies in the analysis. How would you do this study again, or do you think that it's even necessary? Do we have enough information at this stage?
So a couple of things. First of all, I wouldn't do a study on BMP off-label at this point in time because there's enough other alternatives. But any off-label use of a product is fraught with, a lot of oversight by the FDA and very strict protocols. And also, using something off-label, we always have to say that. We're at the Academy meeting right now, we're discussing off-label products, and you have to disclose to your patients if you're doing that. It makes people less hesitant to participate in a randomized study. The study design can't be successful in something that is controversial. That's the biggest thing I would learn. We had to combine the data so that we would have something to actually compare to and to give you results. And a lot of times the big lesson learned, you have a hypothesis. We didn't prove our point, but we learned a lot from this study. And we learned that the good old standard was better. So you have to be prepared anytime you're jumping into a research project that you might not get the results you want. And then therefore regroup with the data you have and with data that is accessible to come up with something for clinical application. That's the lesson.
And so you talked a little bit about how this sort of may or may not have changed your practice. Do you think that it changed practice amongst other surgeons, or what was the discussion at the time the paper came out, or at the time you were doing it?
So at the time we started this study, there was a lot of enthusiasm for it. It was actually, like I said, the first big metric study that was going forward. We had the IDE in place, we had the IRB in place, and then the negative press with BMP in the spine literature, and also the research that was used to get the BMP indications for spine was flawed. And therefore it made people less trustworthy of this. It was like everyone jumped on the bandwagon and then they jumped off. So you have to proceed with caution, and perhaps we should have stopped the study earlier. And there was a lot of discussion on that, but there was a lot of money vested in it as being the first clinical trial in metric.
Right on. Well, I don't see any questions from the audience. So
Dr. Canada, I have a question, if it's all right if I ask one.
Of course, yes, you can.
Congratulations on doing this. These are obviously incredibly hard trials to run. And it sounds like to me that most of the lessons you learned revolve around doing research and working with the FDA and doing some off-label stuff and the difficulties and challenges surrounding that. But clearly there's a pearl in there somewhere that the ABOS thought was very important from a clinical practice standpoint. What do you think that clinical pearl is that those who may are listening to this now and maybe listening to it in the future need to take away as something kind of the most important or salient point that they can take home, and it can to some degree impact clinical care?
So when being tested by ABOS, I want to know in your thought process that you refer to evidence-based medicine. This provides some evidence-based medicine for those people that do use RHBMP2 in certain situations. It provides some background that you can tell your patients and that you can tell your examiners and why, and you chose to use this over other products. This gives you some information that can be used.
Well, I think if there isn't any other questions from the panel, I want to be mindful of your time. I know you've got to run, but thank you very much again for doing this with us. And yeah, I think it definitely gives us a bit more information about BMP2 for the listeners.
Yes, thank you very much. And this is an awesome event you're doing. Have a great evening.
Thank you.
All right, so we'll go to our next video. Chris, if we can play that.
All right, everybody, welcome back. I'm here again with Gerard Slobosian. As a brief introduction, he's a friend and mentor of mine, works at the University of Maryland, Baltimore, where he is the director of clinical investigation at Shock Trauma. And we've previously actually done a journal club together. So this is the second one of his articles, which has been selected by the AO North America Trauma Journal Club. So congrats on that. kudos. That means you're doing some cool research, I think.
Thank you. Thanks.
So thanks for joining us again and giving us some of your time. The paper we're going to review today is titled Effect of Extended Prophylactic Antibiotic Duration in the Treatment of Open Fracture Wounds Differs by Level of Contamination. So the theme of the AO Trauma North America March Journal Club is to be reviewing papers that were selected by the American Board of Orthopedic Surgeons, or the ABOS, for their web-based longitudinal assessment program. So this is a way now that people are basically keeping their board certification, and this is one of the papers that the ABOS selected. I'll introduce the paper quickly and we'll get into some questions. So this paper is a secondary analysis of data from the FLOW trial, which, as we all know, at the time was the largest randomized controlled trial in orthopedic trauma surgery, looking at irrigant strategies in open fractures. And in this secondary analysis, 2,400 patients from the FLOW trial were analyzed, with the objective being to determine the association between prophylactic antibiotic duration after definitive wound closure of an open fracture and deep surgical site infection. So what you guys did as authors, you took 2,400 patients from the FLOW trial. You evaluated patients that had antibiotics following definitive closure up to 72 hours and compared those against a group of patients that had antibiotic duration following definitive wound closure, definitive treatment for greater than 72 hours. And I would say that the findings of the study are quite interesting. And without getting into too much of the nitty gritty, the primary finding here is that extended antibiotic duration resulted in lower odds of surgical site infection amongst patients with severely contaminated wounds. But those patients with mildly contaminated wounds, which was something determined by the surgeon, the degree of contamination, were maybe at increased odds of infection. So we'll just start by asking sort of what was the genesis of this paper? And secondly, why do you think it was selected by the ABOS as part of their web-based longitudinal assessment program?
Sure. I'll start with that second question first. Certainly it's an honor to be talking about our research in this journal club, and it's certainly an honor to have your work picked for the ABOS and the longitudinal assessment. I suspect the reason they picked it is twofold. One is this is a legitimate clinical question that most of us need to ask, which is, how long should we continue prophylactic antibiotics? This is something you'll decide for every single one of your open fracture patients. So I think it's very clinically relevant. And then I think the ABOS reviewers also recognize that it comes from one of the best data sources we have right now. And, this analysis is a secondary analysis of the FLOW trial, which was led by McMaster and Mo Bhandari and all the collaborators across the country and across, the world that participate in this. So I think this is, the best available data that we have, and it's highly generalizable because it comes from so many sites across the world.
And what was the motive, to look into this topic? I mean, was your motive similar to why you think it was picked, and that it's sort of a broadly applicable topic that has the opportunity to have a high impact on care?
Yeah, I think, as I mentioned, this is clinically relevant, and I struggle with it in my own practice, right? Because antibiotic stewardship is a hot topic. It's an important topic. But sometimes I feel like just following protocols takes away the thinking and the actual clinical acumen of the patient in front of you, right? So we know that protocols help with standardization. Standardization sort of helps us get around random variation that, probably shouldn't be there. But I think there's important times where you may say 24 hours of antibiotics or even no postoperative antibiotics doesn't make sense for this patient. There was dirt, there was, grass. I was picking it out for an hour while I was doing this debridement, and maybe I should treat this patient a little bit differently.
Yeah, and I think that was one of the very unique aspects of this paper. Work like this has been previously done, and there's even meta-analyses done in this arena. But what was unique about what you guys did with this paper was stratified the patient cohorts by the severity of contamination. And that ultimately ends up being, a primary driver of of your outcome and the conclusion of this paper, which I think is important for the readers to understand when they're reviewing this, as I imagine it will be something that the ABOS is focused on, is the difference in the severity of contamination. So explain to me a little bit what you think, or the reason for the disparate conclusions between the mild contaminant group and the effect that prolonged antibiotics had on their outcome. It essentially increased the odds of surgical site infection, versus in the severely contaminated open fractures, the extended antibiotics, so greater than 72 hours, was protective against surgical site infection. Why do you think the sort of disparate relationship occurred?
Yeah, so I think there's a few things that are worth talking about in this question. The first thing you mentioned is that, some of this work has already kind of been done, but it hadn't been done based on wound contamination. So other people have looked at this question based on Gastillo-Anderson class. And of course, wound contamination and Gastillo-Anderson class will cluster together. It's pretty hard to get a really severely contaminated wound and have it be a type 1 open fracture. It just, that doesn't really happen. So the two definitely go together. But one of the things I've learned, and a lot of us have learned over time as we do these multi-center studies, is that a 3A and a 3B may not be the same from institution to institution. And same with a type 2 and a 3A may not be the same. And there really is a lot of variation in what people think about those injuries and how they classify them. And some 3A tibias, for example, may actually be kind of benign. I'll use that term a little loosely, right? But the wound management, the soft tissue injury really isn't that bad. And so looking at wound contamination, I think, really gets at probably what we were trying to describe originally with the Gastillo-Anderson as well, right? So I think that that's a much more important marker. And it's also, from a biologic infection perspective, it's, I think, a lot more pertinent, right? If you have a lot of soil and grounding contamination, that's definitely a lot more at risk for infection than something that's just a big wound but was completely clean. So that's the first reason why we did it in this way, and I think a big advancement into our analysis. In terms of why we saw the results we saw, which means a big effect, a big protective effect for extended duration in severely contaminated wounds. Again, I think that fits a biologically plausible and important mechanism. In terms of the mild wounds having an increased risk of infection with prolonged antibiotics, I think it's important to look at the way the trend goes, right? So the highest risk, like you said, is in that mild group, but even those results weren't statistically significant, right? And so that point estimate, I think, was 0.139 for the odds or something like that. And then you get to the moderate and it's like 1.05 or somewhere around there. And then you get to the severe, it's 0.2, right? So you're seeing everything move in the same direction. So you're not having a bunch of spurious results in that regard. You see that the first two estimates cross zero and are cross one and are not significant. And then you see a very strong signal where it makes the most biologic rationale. In the paper, we throw out a few other potential explanations why you could see this, and one being that the less severe open fractures, there's data out there that shows that the time to first antibiotics for less severe open fractures tends to be longer, right? So it's not that impressive. So people don't get them the timely open fracture antibiotic prophylaxis that they should have in the emergency department. And that in itself, of course, could cause an increased risk for infection. But those are all just theories. But I do think that the overall trend of the point estimates getting stronger and stronger and stronger and supportive of extended duration as the wounds get more severe, I think is the important take home from my perspective.
Yeah, I think so. And it's nice to see that consistent trend, exactly how you described there. And I would congratulate you guys. I don't want to get too much into the weeds of the statistics, but congratulate you guys on doing a very sophisticated statistical analysis and stratifying and using propensity score matching to do all these things to give us the most reliable result to trust. Because it's interesting when you look at just the unadjusted analysis of all this data, nothing is significant. But you guys do a nice job of detailing why you looked at these different strata and how the strata can confound and the reasons that you used these strata and propensity score matching to give us something that we can believe. How has this paper changed your own practice? Is this something now where if a wound is severely contaminated, you're doing more than 72 hours? And if so, how long is enough and how long is too long? And for those non-severely contaminated wounds, are you being sure that you only give those patients, say, 24 hours of postoperative antibiotics?
Yeah, so I do have to just publicly acknowledge that most of these decisions initially are being made either by the trauma team because they're multi-trauma patients or our infectious disease partners. So on the day-to-day decision making, I really am not that involved. And I also the literature would suggest that it probably doesn't matter, right? So if they're strong proponents of 24 hours and antibiotic stewardship and they cut them off there, it probably doesn't matter. However, for when this paper and this analysis has changed my practice, when I do have severely contaminated wounds, I make sure I communicate both the findings of this study, both the findings intraoperatively, and that I want longer antibiotics. And I certainly say at a minimum 72 hours. These cases aren't that common, to be honest, but I prefer 72 hours to even up to 5 days, because these severely contaminated cases aren't walking out of the hospital the next day, right? So it's not like I'm delaying their discharge or things like that. These patients tend to be in the hospital a lot longer. They're at a high risk because their metabolic demands and things like that from their multi-trauma as well. And these are patients that I just feel that I need to advocate more for a more thoughtful approach to their antibiotics, not just a protocolized approach.
Yeah, for me, I think this is a case where this is something that would lead me to advocacy for that very reason in the more severe cases, I think. I was surprised by the amount of patients who received greater than 72 hours of antibiotics. It was like 42% of the patients in this study, because I think it's just because of the institutions I have been at are heavily protocolized and people are very into antibiotic stewardship, and we very rarely do anything more than 24 hours. So I found
some of that is purely regional differences, right? This was an international trial in many, many countries, and there are regional differences there. There are other countries that do routinely use prolonged antibiotics and stuff. And so that allowed us to answer this question and have enough variation to be able to explore this.
And one kind of tough question for you. How do you think this was sort of before the time that local application of antibiotics was really a fad? Would that be an accurate statement?
Absolutely.
And how do you think that maybe affects the results of these? So now people are getting these severe open tibia fractures and they're dumping a couple grams of local antibiotic powder into the wound.
Yeah, I think it's a little bit hard to answer with direct data, but I think we can put together a few pieces of indirect data that can help us. So the first, issue, of course, is, are prolonged antibiotics leading to bacterial resistance and causing problems there, right? Because that's the whole antibiotic stewardship issue. And we know that prolonged antibiotics certainly can, right? But we have a real problem on our hands with these severe cases, right? So the infection rate in this series, in the flow trial, was 23% for severely contaminated open fractures, right? So that's way above the risk of antibiotic resistance. Second, this is still a relatively short dose, short course of antibiotics. And I don't think that is going to be just the right amount to create resistance. It may be, but I really don't think so. And I think we've got a bigger problem that we need to tackle, the high infection rate. Now, when you add the local antibiotics, you have to think, is giving 3 days or 5 days of systemic antibiotics plus a really high dose of local antibiotics, is that going to cause some sort of systemic problems? And I think it's important to recognize that there's been a bunch of data looking at this. And frankly, if you dump 1 gram or 2 grams of vancomycin powder into the wound, almost nothing gets absorbed systemically. And so that tells you that it's still very, very safe. So as long as you're safely doing your IV doses, it's unlikely that the local dose is going to take you to some high systemic problem. So I think I put all that together, and I'm okay with the practice of both, even though we don't necessarily have data looking at both at the same time.
Awesome. Thank you. That's great wisdom. Last question for you. Do you think there's any role in severe closed fractures, like highly comminuted or segmental closed fractures where the soft tissue envelope is not compromised to the point where the fracture becomes open, but we know there's severe soft tissue and internal degloving? Do you think there would be any role for extended antibiotics in those patients based on this data?
Well, certainly this data doesn't help us answer that question at all. But so now we're just talking about my opinion. I do think that probably the local antibiotic administration is probably the way to go here. As I mentioned, we need to be thoughtful about when we're doing something outside of the standards or the protocols or whatever, right? And the reason we were prolonging antibiotics for severe open fractures is there was tons of ground dirt and debris in the wound, right? So there's a very clear immediate threat to the to that wound getting infected. There was bacteria in that wound. A closed fracture is not that situation, right? Instead, the closed injury, even if it's severe, is at risk of the soft tissues not being able to fight any infection that is introduced during the surgery, more iatrogenic. So I think that that's less of an issue, and a very high local concentration with antibiotic powder should be able to handle that.
Yeah, awesome. That puts us right at our time limit. So I wanted to thank you again. This is obviously the second time you and I have got to do this, which is always fun for me, but I really appreciate your time and stepping away from your busy schedule to go over another one of your articles. And also, again, congratulate you a second time. This is cool that your work is, to me, what it means when the ABOS selects your paper is that you're doing the research that has the opportunity or should be changing, or at least at the very least guiding practice. So I think that's an incredible compliment. And again, congratulations. We can't thank you enough for joining us again for another version of the Journal Club.
Well, thanks again, Lucas. And I'm humbled by those kind thoughts and words. I really want to spend most of the time just thanking all the flow investigators, right? Because the coordination from McMaster, Mo, and Sheila Sprague, and all the investigators across the world, right, that contributed to this, we wouldn't be able to answer some of these questions secondarily if it wasn't for that vision and all that effort. So I think that's wonderful. And thanks again for having me.
Yeah, cool to see that this work continue outside of just the primary trial to continue to help us answer important questions. So exactly. Thanks again.
All right.
That was great. Just in the sake of time, we're just going to go on to the next video, but I think there's a couple questions that have come in, so we'll loop back to those once we've done these next two videos. We're going to shift gears a little bit into hip fractures. So let's roll to the next one, please.
All right. I'm Kyle Schweizer from the University of Missouri, and we are joined by Mai Nguyen up in Minnesota. We're going to be talking about her paper, The Impact of the Fascia Iliaca Block on Pain, Opioid Consumption, and Ambulation for Patients with Hip Fractures, which is a prospective randomized study. So thanks for being here with us today.
Thank you. Thank you for having me.
So what prompted you to conduct this study?
Yes, Kyle, it was a really fun study to do because that was my first year out fellowship, and I know that I wanted to do research, something relevant for my trauma patient, and I picked out hip fracture as one of the topics because so many of patients that I treat have this problem, and that's also a shared passion between me and other trauma partner in the group. So I know that I would have support, and so we all fresh out fellowship, 5 of us started out at Texas Tech. We wanted to follow everything like by the book. We want to follow the AOS guideline. And we knew at the time that the hospital were not really giving priority for hip fracture patients. So we really want to make changes. And we were forming task group to meet with member representative from internal medicine and anesthesia to try to improve care. At the same time, I don't know if you remember back in 2017, when I went, I remember vividly going to national conference and hearing all this priority and talks on the opiate pandemic and the role of orthopedic surgeon play. And I got home, I felt really excited about this topic, and I felt like I need to do something to contribute as a surgeon into this national effort by our national organizations. And the OTA and OS did a really good job trying to put up a public announcement and showing us how important this topic is for our trauma patients. So I went home, talked to my group about how we could do that, and go back to my group when I was meeting with anesthesia and medicine. For orthopedic surgery, we all tell them that we can get patients to the operating room within 24 hours from their injury. And we wanted to hear what they want to do from their standpoint to optimize the care delivery system. And I remember my anesthesia partner, he was telling me about this block, fascia iliacal block, and wanting to do this for all hip fracture patients. And I told him, Jasper, I've never heard of this block before. I looked up in the literature. He told me that there's great evidence to support the use of the block. But the only papers I could find was in anesthesia literature and emergency room literature, which I knew that if we want to roll this out for hip fracture patients, we need to have some data within the orthopedic literature. So I learned more about the block. I followed him and actually timed him to see how fast they could perform the block effectively. And it took them 5 minutes to do that from the time that they start collecting medication until the block is completed. I follow my patient who has a block who have very good results. And I knew that we have enough information to be able to do a prospective randomized control trial on this topic. So that's how the study idea started.
And what do you think the main takeaway from the paper? Like if you were gonna, go through and you wanted one thing to be kind of conveyed to everyone, what do you think that would be?
Yeah, and I think this is the importance of teamwork in orthopedics, not only about our paper, but also the national efforts of other team as well on this topic. So the overall message for this study and other study would be, the advantage of fascia iliacal block for hip fracture patient. And for us, the single takeaway based on our intention to treat analysis would be that single perioperative block for hip fracture patients can decrease opiate consumptions and increase the likelihood that the patient can able to be discharged to home instead of to a skilled nursing facility. That would be the takeaway.
And do you think that the reason, what do you think the reason is for the more likely to be discharged home? Is that the requiring less opiates, so they're a little less, usually a little more alert, or what do you think the reasoning behind that is?
That's a great question. And I mentioned before that, this is one of our efforts looking into quality improvement for hip fracture patients. And I think something that's unique in our paper is that we're trying to bridge that connection between pain and function. And I think because it's all tied together, and if the patient have better pain control, that would translate to some improvement in immobilization, in able to mobilize faster. And if they can mobilize faster, they can be more mobile. They need less assistance and able to discharge to home instead of to a skilled nursing facility when they require a lot of assistance still. And so I think it's tied together. It's probably impossible to tease out exactly the causative function relationship between this variable, but I think that's the combinations of better pain control, require less narcotic, probably less side effect from narcotic medications, and ambulating better.
What do you think was the kind of the main limitation to this study?
So you can tell from my study, I think the most downside of the study was that the crossover was really high, close to 30%. And I should have mentioned earlier there that I want to use this study as an example to encourage people to do research with little funding so that you don't feel discouraged. You don't feel like you need to be at a powerhouse to do research, but also understand the drawback from that. So this study was a randomized control trial. We registered the study in the registry of randomized control trial for orthopedics. And that was a study that I'm pleased and really proud of our group to say this, but we did this with zero funding whatsoever. There was no funding for the study. It's really done based on the hard work of the team member. And because of that, we didn't have a research coordinator to be able to closely follow the patient to ensure that they follow the treatment branch. Rather, once we assign the patients, we just let the rest of the care after the block to just play out the way that the standard post-op protocol for hip fracture patient would be carried out. And because of that, we had 18 patients who should not have a block, had a block, and 12 patients who's supposed to not have a block, cross over to the other try. So because of that, you can see that we have to analyze our results based on intention to treat, based on as treated analysis and per protocol because of the high crossover rate. So that's something that I definitely highlight as the limitation of the study. But orthopedic surgery is tough, and there's a lot of smart people in our field. Whenever I apply for a grant, I had to compete with you guys who are super smart out there, and as a result, I have not been able to secure really any grant from the OTA, ORF, and so it is tough, but it's doable. For this study, basically I posted my personal contact information out there. My residents who involved with the study help with recruiting patients as well, but I basically tell the rest of the hip fracture team in the ER and what anesthesiology is that if you have a patient who have a hip fracture, I don't care what time of the day it is, if it's a weekend, call me and I will make sure the patient is enrolled. So it's really a poor man way of trying to perform a randomized control trial based on the limited resource we have. And that's a result that we have pretty poor crossover rate.
Well, I mean, it looks like that hard work paid off for you, though, at least for this study. And I think that's a great message for everyone who's watching this, or just anybody in general. Like, research is hard. There's a lot of roadblocks for sure. Resources, funding, getting anything published. I mean, there is so many roadblocks in research, and sometimes it's just all about persistence and hard work, and that you can definitely get things done. So don't feel like you have to be, super well funded all the time. And if you have an idea that you're passionate about, like, you should definitely pursue it. I think that's a great message.
Absolutely.
All right. Well, we really appreciate you being here. It was a great study, and we appreciate your thoughts and comments on it. So thank you very much.
Thank you. It's my honor to be here today.
Fantastic. And then we'll roll the last one and then open up to questions, both from the participants and from the moderators and our guests. Good evening. I'm Jason Stralzo. I'm an orthopedic traumatologist and upper extremity surgeon from the University of Chicago, and it's my great pleasure to introduce one of our first papers this evening for our journal club from David Gallos and his group. And this is entitled Unnecessary Preoperative Cardiology Evaluation and Transthoracic Echocardiogram Delays Time to Surgery for Geriatric Hip Fractures. This was published in Journal of Orthopedic Trauma in 2021. Dr. Gallos, thanks for joining us, and maybe tell us a little bit about yourself.
Hello, I'm assistant professor of orthopedic trauma at Temple University Hospital. Temple University Hospital is a level 1 trauma center in a large urban setting. I joined there in September of 2020. Prior to that, I was working in a level 1 trauma center on Long Island, where we saw a large number of geriatric hip fractures.
So maybe start us off with just sort of describing the genesis of this project.
So in our hospital on Long Island, where I was practicing, we had a large volume of geriatric hip fractures, and we had a geriatric hip fracture protocol that included a multidisciplinary team. And we found that oftentimes on part of the optimization and workup for the patient prior to going to the OR, in our safety net hospital, we were getting a lot of cardiology consults that seemingly were delaying some of the patients getting into the operating room. If the optimal time to get into the operating room is anywhere from 24 to 48 hours, oftentimes that was being stretched a bit. And when we looked at the actual criteria for what was recommended for necessitating further workup by subspecialty medical practices, oftentimes we saw that our patients didn't necessarily meet that. So we were interested to see what that, how that was factoring in our institution, as we think that being a safety net hospital, that might be quite similar to other safety net hospitals in and around our country. And so this might be something that's similar elsewhere, and this data would hopefully be useful as a way to streamline and get patients into and out of the OR a little bit quicker.
For those on the call that maybe don't or aren't familiar with the term safety net hospital, maybe just expand on that for us just briefly.
So the hospital itself is a county hospital. It's funded by the state, and it's essentially takes all comers, regardless of any sort of insurance status, and tends to be a hospital, a tertiary referral center as well. So
3 takeaways from the project that you sort of hope people at least understand and maybe bring back to their institutions.
Number one, I think the most important thing is that seemingly we're ordering too many consults, specifically cardiology, and too many transthoracic echocardiograms. Number two, I think that those, and the data in our article kind of highlights this, leads to a delay in patients getting to the operating room. But as a third point, when patients did get those cardiology consults and echoes, it did not lead to a significant increase in number of interventions that would have prevented any sort of complication for the patient. So we're really not adding any added safety, and we're just delaying care.
Yeah, I have to say, I thought that was one of the most interesting parts of the entire paper, was the fact that you had all these interventions, but at the end of the day, all these investigations, but at the end of the day, not a single patient in the population ended up receiving an intervention, which kind of would tell you that, just like you explained, maybe we're not actually adding benefit, we're just sort of making ourselves feel better, but not actually doing better patient care, so to speak. I guess one of the questions that comes out of that is, did you or do you have an expectation that you might look at things like cost analysis specific to this problem? Because I know you bring that up in the discussion a little bit about the general cost of taking care of geriatric hip fractures and some of the costs related to the investigations.
I think that's a great next step, obviously, understanding how this affects patient care, but then also being able to monetize that to a certain degree in the current structure we have, where cost containment is of significant importance for hospital systems, and a way to curb that. If we are more diligent and careful with our consultation and use of various imaging studies, then this might be a way for hospital systems to decrease the cost, because the cost burden, especially in areas where the geriatric population is high, can be significant. So that would be, I think, an important thing to look at, and I think that's a great next step. And we haven't gotten there yet, but I think that's kind of the natural progression for this article in terms of where to look next.
I think especially in like you said, in light of the recent studies that have sort of been trying to pin a specific time frame for the optimal care for these patients, even a study that's retrospective, I think adds a lot to that, given this is one component of maybe some of those delays that end up potentially having a negative impact on patients. I think your discussion of trying to do something maybe prospective, looking at the outcomes, whether there was a change in outcomes, would probably be a great next step. It would seem so. Look forward to that. I guess one question I have from our institution, we co-manage a lot of our patients with hip fractures. And so where do you think the burden lies in terms of the consults? Now, obviously, for our patients over 65, like the patients in your study, they have an automatic hospitalist consultation for assessment. And then they often dictate that cardiology follow-up or that next step. I wonder, did you look at that, and was that at play in the current study?
No, so I mean, in our geriatric hip fracture protocol, we had a multidisciplinary team, but they were on a trauma service, and they were automatically put into an elevated care setting, like an ICU type setting, and they were being managed mostly by the trauma team, and they made many of the medical decisions unless there was something that really was above and beyond their capabilities. However, there are obviously a lot of other institutions that do have a medical co-management model. And I think that works very well. And I think oftentimes the default is to listen to the medical colleagues about getting consultations. However, I think it's important that we're all educated in what would necessitate an appropriate consult. And I think when you have a good working relationship with your colleagues, then it's safe to reach out to them when there's a question about whether or not this consult is really needed. And having an open door policy about having these discussions, I think, is worthwhile and something to strive for, because ultimately, there may be a very valid reason to get a consult, and we as orthopedists may not be as privy to those because to that knowledge, because we don't necessarily have the same understanding as they would. But at the end of the day, we can, we have some data we can, certainly lean on and say, look, well, we're not so sure that this is appropriate. And, if they, feel the same way, then oftentimes I think, and oftentimes they would change their mind about getting it. And, especially if you show them the data. So I think it's not just, we just acquiesce to another service's kind of wants and needs. I think it's a discussion, and it should be evidence-based on both sides. I think sometimes I think that our medical colleagues may not understand the expectation or the benefit that a patient would have by getting to the operating room in an expeditious fashion. And so, our job, I think, is to raise the bell, or raise the that point to them in a way that they would understand it, and hope, show them that the benefits of doing that extra workup is not going to really, lead to anything, and the risk would be increased significantly for the patient.
Your study, did you look at whether the TTEs were being asked for by the anesthesia team, or whether this was strictly just by the cardiology team?
I mean, the way that we had it was from the cardiology team, but just from my own experience anecdotally, our anesthesia team they were pretty very much on board with trying to minimize these cardiology input in the consults when it wasn't necessary. So they were really not a roadblock for us in this situation. So they were quite helpful.
Well, that's great. That's all the questions I have for you. I really appreciate you taking the time this evening to chat with us, and I look forward to the discussion and questions that arise.
Thank you so much for having me. I appreciate it.
Great. Well, thank you all, both moderators and then the guest authors. We really appreciate the time you took to both reply and give us some answers to some of the burning questions we had about your papers. I think there's a few questions that have come in. I want to make sure we get time to answer those. So I think for Dr. Slobosian and Lucas, I think there was a question about whether and anyone on the panel truthfully can answer, but are you doing primary closure of wounds or secondary closure? I assume this is in relation to sort of dirtier or type, probably type 2 and type 3A wounds, but maybe give us the current practice you have in terms of primary versus secondary closure.
Sure, I'll go first if you don't mind. I just want to clarify that the study was anchored off time from definitive closure. So I realize that's a slightly separate question, but just so we're all clear, the duration of antibiotics was based on time from definitive closure. And I'll just add my 2 cents in terms of primary versus secondary closure for dirty, heavily contaminated wounds. We're not typically doing primary closure on the first night. They're getting at least 1 to 2 debridements in those situations.
That'd be the same for me. And I think on another important point, until the wound is definitively closed, it has been my practice to continue antibiotics. So in those heavily contaminated wounds that are getting multiple washouts, those patients are getting washouts in the interval spanning time between OR trips, which I bet most people are, and is why I bet Dr. Slobosian and authors looked at antibiotics after definitive closure, because there are probably a certain number of wounds that get antibiotics for a week in-house while they're having 2 or 3 trips to the OR, getting multiple washouts.
Anyone else do anything differently on the panel? That's certainly, I follow pretty much the same protocol. So I do have a follow-up question to that, if that's all right. What's everyone using for antibiotic prophylaxis? So, and not pre-surgery, but in the post-op. So let's say you're planning to do 72 hours of antibiotics. What are you using, and who's guiding that for you?
I hope you're asking Lucas.
Yep, that's who I was going for.
No, Slobosian's got a great answer to this, I'm sure. But for me, it's just ANSEF, unless I've identified some other pathogen or I have some concern that the wound is contaminated with something out of the ordinary, in which case there'd be a consultation to the infectious disease team looking for guidance.
Yeah, I would just add, at our institution, we're famous for saying something that's a bad idea, and then going right back to doing it, or saying we do this and then not doing that. So I will say that we were very concerned with aminoglycosides in trauma patients, under resuscitated, et cetera. And I think you still need to be careful of that. And so ANSEF just in that situation, I think, is reasonable. But for these heavily contaminated wounds that are getting multiple debridements and are, kicking around your ICU for several days, hopefully you've caught up on their resuscitation and now they are capable of receiving aminoglycosides or more broader spectrum antibiotics. And so we do kind of move back into that approach for those heavily contaminated wounds. But as I indicated in the interview, a lot of times I'm not involved in those actual decisions. And the other thing I would comment on is a lot of institutions have moved to other, third generation cephalosporins and things like that instead of ANSEF plus Gent or whatever. That has not been our practice per se at Shock Trauma, but I think that that's still a very reasonable practice, and there's a lot of regional variation in this area right now.
Yeah, I totally agree with Gerard's last point there. I think this is highlight a very important point, that trauma is very regional. And so I think we should look at our own data, institution data, because I think our patients are different. I mean, this is, the hospital I've been at in the last 5 years from fellowship. So you can see, right now we're using mainly ANSEF, but I remember when I was a resident at Iowa, we look at our infection rate for type 3 open fracture, or type 2 and 3, and we realized that a lot of our patients end up having surgical site infection and it was gram negative. So ANSEF didn't cover them very well. So they have a protocol. They have to have aminoglycoside and one single dose so that it does not affect your kidney and your hearing function and things like that. But that's regional. And then everyone probably remember the data from Vanderbilt. One study, they found very high rate of MRSA colonization among their patients. So because of that, they choose to cover MRSA for post-op patients that have high-risk wounds. So that's something I've been pushing for my institution to look at our own data, because most of the time we use NSAF, but I can certainly have seen cases that came back with gram negative that NSAF didn't cover. So I'm getting a little bit more aggressive with broader coverage. But that's something that I don't think that orthopedics had quite agree on those type 2 and type 3.
I'm glad just to hear that there's variation, because our center, our ID people have really pushed us to go to 3rd generation cephalosporins. So, your 3As and above are really getting ceftriaxone, unless there's some allergies. And we've kind of pushed ourselves off of the aminoglycosides, which, for better or worse, I don't know. We don't have enough data yet to know whether it's working, but great.
I'd like to echo that too. That's what we started doing in Philly as well recently.
I'm glad we're not alone. That's good to hear.
Ceftriaxone's been the new go-to.
All right.
Sites have done that, and Carol Lynn's paper in JBJS using PREPIT data has also shown that. So, once the PREPIT trials, which are 2 large trials with 10,000 patients, are completed in the next year, we'll be able to start looking at that question a little bit more. And to Mai's comment as well about, let's look at our institutional data, let's look at the practice variation across the country.
I want to ask a question about your paper, because we have had similar struggles in our institution. We've been trying to build sort of an institutional protocol around using the fasciitis block. One of the things that I'm fascinated by in the literature is some of the discussion about whether it affects mortality, and the ability to get patients up early and potentially get them off some of these drugs that decrease their respiratory drive, et cetera. Did you, or do you have any plans to look at that as part of your study?
Jason, that's a great question. So when I designed the study, I wanted to look at a few things around the block, because there was no information in the orthopedic literature about this particular block before. So one, I want to make sure that it's safe. So for example, a lot of anesthesiologists didn't want to do a block on patient who's anticoagulated, right? And we still have to do those block on patients and still get them to the operating room, even though they're on Coumadin, they're on aspirin, Plavix, and all that. And so number one, we showed it's safe. We show that there's 0 complications in any of those patients that related to the block. Second, we want to make sure that it's helpful in terms of pain and in function, and we show that it is. And I also want to highlight that this is not the only paper to support that. I mean, David, I just texted him, he had a great paper on that. There's a body of literature now that support that is helpful in terms of pain and function. And the third one, I want to make sure that it's actually offset those side effects of narcotic. I mean, why we don't want narcotic for patients, we have to show that this effect is actually clinically meaningful. So in my paper, I also want to look at the other medical complications and the other side effects that is associated with narcotic, like delirium, constipation, and all of that didn't pan out the difference. So I think that the number one, the analysis that we picked for the power analysis is based on VAS score. So because of that, the number of powers was low. But I think that if we want to look at the other complication as well, medical complications, all those details, we would have to have much bigger number in order to amplify this effect. I mean, it's common sense was to think that if patient use less narcotic, they would have less side effect. But in order to show that statistically significance that everyone is wanting to show, I think we have bigger numbers. And one more thing I want to highlight that was difficult for the study and very related to your questions is I think that patients who are most at risk probably would be the patient that would benefit the most. So those are the patients who could barely move even before surgery. So they go from barely moving to not moving at all after hip fracture. They are the patient who have severe dementia. And unfortunately, because of the design of my study, I'm not able to capture them well. I mean, how do you enroll randomized control patients when they're not able to provide consent for themselves? So we intentionally excluded them. And because of that, there's no patient with dementia in our study. And it's been one of the drawbacks in the study. I think for David's study, they also have to exclude dementia as well, for patients who are not able to provide consent. But I think that to answer your questions about the block, I think a lot of bigger data need to be pulled together. I think the effect is there. Whether we're able to prove statistically is another problem. But so far, it's been part of the guideline of AOS and all organizations that any block that you can do for patient, any effect that you can decrease their pain and then narcotic use will be helpful for hip fracture.
And I'd be interested in from anybody on the panel, one other way that you can use a fasciolata block, which some of the attendees may not think about, or when you read this paper, it's another way, is that when we have patients who are going to be delayed for medical reasons or for whatever reason, they can't have surgery within that 24 to 48 hours, or they're just, too sick and they're likely, not going to be able to go to the operating room, we'll actually do fasciolata blocks on the floor to let them mobilize and get in a chair and not lay in bed for 4 or 5 days while waiting on medical clearance. And so I don't know if anybody else has experience with that, or
that's really interesting. I mean, I think waiting 4 days for medical clearance is a crime in itself, but I first learned the fasciolata block when I was a resident, no ultrasound, and I'd say me personally doing it in the emergency department had probably a 75% success rate, totally blind and really not knowing what I was doing. And so I think now that the literature has gotten better and people's experience have gotten better, I think that's a great idea. I think we should really try and promote this sort of practice. And just as another random aside, as being on the OTA program committee, there are a lot of papers this year, submissions that have, that are continuing to show efficacy. And a lot of them probably won't, get accepted just due to the sheer volume of the number of things that we get. But that overall body of literature continues to move in the same direction. And I think we need to be cognizant of that.
And Kai, to your point, so our protocol is actually the moment they hit the emergency room, we call it the cold hit protocol. And now my paper to follow up on this, but they got to emergency room. We identified that there's a hip fracture. The operator sent a text page to orthopedic surgery, anesthesia, and that's it. So the anesthesia team goes see the patient to see if they candidate for block, do the block right there, so the patient can actually have the benefit from it right away, regardless if the surgery is going to be that day or the day after. And I think because of that, our analysis get a little bit messy, because in the, like when was the block done, and then when the surgery was, and then when you can see the VAS pain afterward. But I totally agree with your point. They get the benefit right away. So why do we wait around the time of the surgery? We just do the block right when the patient experiences pain. And then go from there. And I think Carol Lynn had a couple of papers on that, looking at the different effects of the timing of the block and what type of fracture. And again, I think getting to gritty nitty details, it can get confusing to trying to figure out exactly what fracture, what patients, but the overwhelming response from all these studies that the block does have with pain.
One of the quick question, and one of the barriers to implementation that we had was the need for monitored bed. So doing a block, there was some push from anesthesia to ask for a monitored bed, and so this precluded a lot of our patients. So did you find that this was an issue? You're shaking your heads. Yeah, I mean, that was our clinical suspicion that it wasn't a problem, but I'd be interested to hear what you said about that.
Yeah, I mean, and I think that's why I want to highlight that even though my studies for several things that we mentioned, the size, the crossover, but we show that there was zero complication related to the block. And even a patient with INR above 2, I mean, the way I see it with my anesthesiologist is like, you go there with an ultrasound, you see exactly where you're going with a needle. The patient can be clear for surgery. When you make an incision through that and put, rod through their hip or you will, Hammy, why is it not safe when you put a tiny needle under ultrasound so you can see exactly where you're going and where to avoid the vessel? And I think that's, even though, you know, we basically show that there's zero complication, there's no fancy analysis, but hey, there's zero complications out of all this block. So, I mean, I think it would be hard pressed to withhold that from patient for, you know, like, why you need to monitor if they can be in the ER or general bed, like what additional sign and symptom you need to monitor after a block.
That's great. Thank you.
Awesome. I want to be mindful of everyone's time because I know we're a little bit over, but I do like the idea of the code HIP, because that just sort of puts everyone's mindset in the right place, especially, you know, when we're talking about the TEs and getting the fasciated blocks and getting anesthesia on board and getting medicine on board. So I actually love that terminology. Anyone have any last minute burning questions before I just pull up a couple last things? Perfect. Everybody see that? So I just want to make sure that everyone knows about our upcoming journal club sessions. So we have one on infections, April 19th. There's a scapular session on the 17th of May, and then on the 21st of June, there's our pediatric session. So please save those dates so you can make sure that you're able to get there. There's this recording, and all of the recordings from the journal club sessions are going to be available probably in the next 24 hours, hopefully on YouTube, and you can find the links at AO North America Trauma. Thanks everyone for coming. Really appreciate you spending the evening with us, and we'll see you next time.